very distinguished panel of speakers today. To begin, we have Dr. Robert Cole. He is the Chief Medical Officer at AutoGenomics. He'll be doing the introduction and speaking about a presentation on women's health, specifically touching on HPV and STDs as well. Following Dr. Cole, we have Dr. Sayo Bachai from DCL Medical Labs. He is the Technical Lab Director at DCL Medical Labs, and he will be speaking on genital mycoplasma as part of STD testing. Following Dr. Bachai, we have William Miller from he's AI Biotech. He's the Chief Executive Officer, and he will be speaking on the operational considerations to enable rapid HPV and STD testing. So that being said, I'm going to go ahead and pass it over to Dr. Cole at this point. We can hold the questions till the end after the three panel speakers have spoken. We're going to open it up to a few questions to the audience, and we'll be able to address those at that point. Without any further ado, here's Dr. Cole. Thank you.
Hello, everyone. It's a pleasure to be here. It's nice to be able to talk about a topic near and dear to me. I spent 25 years of my life providing care to women, and women's health is a fascinating field. When I first started my residency, when I first started medical school, I didn't think I was going to become an OBGYN. But I found that the diversity of the care that I provided for patients was fascinating. You could be a primary care physician. You could specialize in infectious disease. You could be a surgeon. And I enjoyed all those elements of the practice. The thing that is fascinating about women's health, though, is that there are moments of profound tragedy taking care of women. There have been moments of deep despair in women's lives over the millennia, and it has brought about moments of great ingenuity and improvement in health care. If we look back to puerperal sepsis, the number of women that died in hospitals because the anatomy labs were right next to the OB wards. The reason the OB wards were right next to the anatomy labs is they were always on the first floor because you didn't want a woman in labor to go up to the second floor. So the doctors that had been working on the cadavers walked without washing their hands to administer to the patients that were in labor. And thousands and thousands of patients died over the millennia from that, well, certainly over the last several centuries from that. And major changes in aseptic procedures were done because of our realization of how we were contributing to those infections. When you think about the development of obstetric forceps, and you think about women that have gone through hours in agony of labor, and the ingenuity that was involved in developing that device, and it saved so many thousands of lives. Well, right now, we are still dealing with huge burdens, healthcare burdens that women have to experience. We're talking about the issues related to breast disease and breast cancer. So we continue to work towards developing diagnostic techniques to diagnose breast cancer early and hopefully to cure it. We also worry about pelvic tumors. We worry about cervical cancer, uterine cancer, and ovarian cancer. We're also concerned about vaginitis and vaginal infections that also affect the cervix and the fallopian tubes and ultimately affect fertility. So there's a wide range of women's health issues that we're addressing. Specifically, the wonders of molecular technology in our ability to address those issues are profound, and we are seeing an absolute revolution in the care of women and our abilities to, with a single sample, which we have actually developed through the process of us devising the pap smear, that single sample gives us an opportunity to collect molecular material which we can diagnose a tremendous number of things with that one interaction with the patient. And that is what we're really beginning to optimize, and that's what we're going to talk about today. Let's talk a little bit about HPV. We're going to just briefly touch on it. There's so much to talk about, but we know that it's a double-stranded DNA virus. There have been more than 100 fully sequenced. We know that 20 million people are currently infected with HPV. And we know that 80% of women by the age of 55 have had an HPV infection. We know that 6.2 million women get an HPV infection every year. Most of them are completely unaware that they're infected. And we know that the vast majority of those infections will resolve, but we do know that for a specific number of those patients will go on to have a cervical cancer. And we do understand now that HPV is the cause of cervical cancer. And as we're beginning to understand what HPV is responsible for, we're starting to learn that it's responsible for vaginal cancers, anal cancers, cancers of the vulva, penis, and cancers of the oral pharynx. 40% of head and neck cancers are directly related to infections of type 16 and type 18. Now, I'm going to have really just a few slides about HPV, but this slide really sums up what is so profound and so important to understand about the difference between HPV and the difference between cytology. Dillner's work here looked at 24,000 women in a variety of different countries. He followed those women for 6 years. He did a baseline HPV test, and he did a baseline cytology test. And what was he able to show? The bottom line is, if you just have a pap smear test, you know about what is happening in terms of your cervix and its relationship to the genesis of cervical cancer at that moment in time. It doesn't tell you about tomorrow. It doesn't tell you about next week or a month later. If you look at this point, the people that just had cytology alone, the genesis of CIN3 occurred within a month or two of the initial baseline test. There is no predictive characteristic to a cytology examination. You do one HPV test, just one. You have totally predicted what this person is going to do, certainly in 3 years, and you can make a case that you've been able to do it for 6 years. The study that was out in the New England Journal of Medicine out of India showed that one HPV test with a woman at the age of between 30 and 35 had a huge impact on the genesis of cervical cancer in that entire population. So what is powerful about HPV is that it has a predictive quality. Now, not only is HPV important, but as we're understanding the topic, we're starting to realize how important understanding genotype is in the management of patients as we become more sophisticated and we're beginning to optimize our knowledge about it. We understand that type 16 and type 18 behave differently than the other risk types. We also recognize that we need to be able to discriminate between persistent and new infections. It is the type-specific persistent infections which indicate the patients that are at the greatest risk for the genesis of cervical cancer. And we're starting to understand that following type-specific persistence gives us an insight in the patients that we need to worry about and the patients that we don't need to worry about, which is ultimately the basis of a good screening test. We want to identify the patients we can focus on and let the other patients go and not spend money on them and not have them waste their time seeing us. We're also understanding the importance of recognizing genotype in a population. Most of the time we talk about how it affects the care of the individual patient. But as we look at overall populations, as we begin to administer immunization programs, we're starting to understand that we need to know what the prevalence of specific genotypes are so we understand what the impact our immunization is having on those genotypes. Now, this is an important piece of information. This is Michelle Kahn's work. This was done in Portland. This looked at 24,000 patients. This was done just 5 years ago, but this has had a major impact on our notion and the technology that we're applying to HPV diagnosis. The bottom line is the top graph is HPV 16, the top line. The second line is HPV 16. 18 and 16 behave profoundly different. Those types of genotypes are the ones that are most profoundly responsible for the genesis of CIN3 or cervical cancer. And because of that, all the technology is moving to try to identify those two types. We look at Hologic's assay, we look at Roche's assay, all the technology is going to identify 16 and 18. Now, why do we want to do that? Well, the reason we want to do that is we have recognized that there's a difference in those two types. That difference is so important that the American Society of Colposcopy and Cervical Pathology has built it into their algorithm. If you are identified with a type 16 or a type 18 virus, you have bought yourself a ticket to colposcopy, because we've determined that the incidence of CIN3 is so high that we don't want to wait. We know that you are at high risk if you are 16 or 18 positive, so you go straight to colposcopy, your cervix is examined, and the appropriate biopsies are taken. If you need a leap or a cone biopsy, it's done right then. Now that is a new evolution in our thought process about HPV. But the bottom line is we're still evolving, and the thought process is continuing to improve. The reality is Jill Kolschel did a major study, one of the largest studies about HPV, and she was looking at not just 16 and 18, but she was looking at all the high-risk, the 14 high-risk types. She basically was able to say that type-specific persistence is a clinical endpoint. The bottom line is if you have one kind of infection and you are unable to clear that one kind of infection for 16 to 24 months, there is a very high chance that you have a cancer there, and you need to make sure that you've evaluated the entire endocervical canal and the entire cervix. So understanding if you have a persistent infection is a key, and the only way that you can know if you have a persistent infection is to know what the genotype is and follow that specific infecting agent over time. So following genotype is a crucial part to management. Now, this is a study that was done by Philip Castle, and he did it in Costa Rica. He followed about 10,000 patients, and he did HPV testing and genotyping testing on patients every year. He wanted to know what is the value of a general HPV test. We're talking about a digene test that will say yes or no for the 14 high-risk types, or what about following the individual genotypes to determine whether there is true persistence. If you look at the top line, those are patients that are what he calls persistent. That means those are the patients that have, for example, a type 18 infection. They have been type 18 for a persistent period of time. Those patients are at significant risk for CIN2 and for CIN3. You can also categorize that as patients that just are positive for a digene test. But let's look at this line, the most important line of the entire graph. It's this line. It's the green line, 0. If you have an HPV 16, and then you clear that HPV 16, but remember, HPV is ubiquitous. Sexually active people get new infections all the time. If you can document that you have a 16, and then you convert to an 18, you have demonstrated you are immunologically competent to resolve that virus. What is the incidence of people that are positive by digene? So they're positive, so they still have an HPV infection, but they are not persistent. The incidence of CIN2 and CIN3 is 0. So I think this is a very compelling piece of information about how we can incorporate this into the management of people. The key element is to find out the patients that we don't need to worry about, and we can focus our time on the patients that we do need to worry about. So the key element, type-specific and persistent.